This is Dr. Cyn, your board certified OBGYN, national speaker, and vulvar skin specialist. Welcome to Unveiling the Private Face. Thanks for joining this evening. As you guys join, please like and share. Hello, thanks guys for joining. Glad you're here this evening. As you know, as we wait for everyone to come into the room, I always like to start with a trivia question. So our trivia question for tonight is, when and where was the first hysterectomy performed? Does anyone know that answer? When and where was the first hysterectomy performed? Hello, Dr. Monique. Thanks for joining. Hello, The Real Renee. Thanks for joining. I hope I can catch all the names. I do have my readers on tonight, but sometimes they don't work all that great. So thanks for joining. As you join, please like and share. Our trivia question for tonight: when and where was the first hysterectomy performed? Does anyone know that answer? The first hysterectomy. Any takers on that? Does anyone know the answer? When and where was the first hysterectomy performed? No answers yet. Greece? Not Greece, but kind of close. Hello, Alba. Thanks for joining. Hi, Tammy. As you guys join, please like and share. The trivia question for tonight is, when and where was the first hysterectomy performed? It was in the 1800s, 1843, Manchester, England. All right, The Real Renee, that is correct. That is correct. So the first hysterectomy was performed in England, Manchester, England, in 1843 by Charles Clay. Very good. Usually it takes you guys a little bit longer, so Renee was on that tonight. All right, so last month we did Ask Dr. Cyn Everything, and everyone has been asking me when we're going to do this again. So here we are. Once again, I am Dr. Cyn, your board certified OBGYN, national speaker and vulvar skin specialist. I help women to understand and optimize the skincare of the vulva, or what we like to call the private face, so they are able to realize that the private face can be just as beautiful as the public face. So tonight we are doing Ask Dr. Cyn Anything. So I asked everyone to send your questions to info at Dr. Cyn OBGYN. I will try to get through all the questions tonight, but if we're unable to get to your question, don't be upset. We will save it, and the following month, we'll make sure that your question is answered. All right, hello, Sheila. Thanks for joining. As you guys join, please like and share. Please like and share as you join. So our first question this evening says, having a painful cycle, should I get a hysterectomy or wait for my change? I have gotten an embolization. All right, so let's go through this question here. First off, I sure would like to know a lot more information. So if this person was seeing me in the office or through telehealth, the first thing I would ask, how long have you been having painful periods? Now, if you're someone who's had painful periods for the majority of your life, it's a strong possibility that you may have endometriosis. Does anyone know what endometriosis is? So if you know what endometriosis is, just put yes in the portal if you can. So basically with endometriosis, what happens is that you get the cells that line our uterus, our lining that we bleed for once a month. That area is called an endometrium. And the cells of those linings are called endometrial cells. So what happens with endometriosis is that those cells get placed other places that they're not supposed to be, okay? For example, they're placed on the ovaries, sometimes on your bowels, things of that nature. So normally endometrial cells respond to our natural hormones. Once a month, We release an egg, either the egg gets fertilized or not. If it doesn't, we have a period. And the endometrial cells cause an inflammatory response based on our hormones, and they fluff off and we bleed. Well, with endometriosis, those cells are other places, and all they know how to be is the endometrial cell. So they have that same inflammatory process on your ovaries, on your bowels, and the body is like, whoa, what are you doing? Because they're not used to that in those areas. So that's what causes the pain with your periods. It can also lead to scarring, which can cause pain even when you're not on your period. It can even cause issues with infertility. All right, so I'm not really sure with this question what this patient's history is. If they had painful periods for many, many years, or if it started later in life. So if this person had endometriosis, could she get a hysterectomy? She could. But the question also stated that they've had an embolization before. So if they had an embolization, that says to me they likely had some history of heavy periods. So with the embolization, it's a technique that we use to treat heavy periods when a wand is inserted through the vagina into the uterus and that wand gets hot, okay? And that wand destroys the lining of the uterus. And so most women really don't have periods anymore after that. Some women do. They're just a lot lighter than what they were before. So with her, I'm really not sure what her true history is. But let's talk about some of the treatment options for painful periods other than just hysterectomy, especially when you've already had an embolization done before. So is everyone on board? Did you guys understand what embolization is? Are we okay? Hello, Yolanda. Thanks for joining. Hi, Tia. Thanks for joining. As you guys join, please like and share. So are we all on board on pretty much what that means? All right. So some of the other treatment options, especially when she's already had an embolization done, we can try some simple medication and see if it takes the pain away. That's worth trying. I'm not sure if that's been done before. I don't have a lot of history here. So there's a pill that's out called Orlissa, Orlissa, and it's FDA approved for the treatment of heavy periods. So that's an option. If you don't want to go directly to hysterectomy, you can try Orlissa and see if that helps control your bleeding. All right. You've had an embolization done before. So did the pain start after you had the embolization? That's another question. Sometimes when women have embolization and we burn the lining of the uterus, you get scarring in that area. So you may have some areas where they're having scarred and there's really no activity there. You're not bleeding from that anymore. But you have other areas where you're still bleeding from. And if the scarring is in front of the area where the blood needs to get out, the blood can get backed up, which can cause a significant pain with your period and can even cause pain when you're not on your period. So my recommendation prior to jumping to hysterectomy is make sure that an ultrasound is done because we want to see what the lining is looking like. Sometimes they even need to do a hysteroscopy, and that's where they slide a little tiny scope through the vagina, through the cervix, where we can see the cavity of the uterus and see if there's anything going on. Some of the medications you can try prior to hysterectomy could be the pill, a simple pill called Orlissa. If the embolization really didn't do much, when they look at the ultrasound and you just got a normal cavity that you're bleeding from once a month, you may even try an IUD, like a Mirena IUD. Sometimes that helps with periods, but it's all going to be determined on what your lining looks like after having that hysterectomy. The other thing you can do is try different shots. They have shots called like Depo-Lupron, okay, which the shots and the pills, they're temporary. but it kind of lets you know what's causing your pain. So if we take your ovulatory process away and your pain resolves, then we know what we're dealing with. Okay. But if you're still having pain, the other option that may be happening, other than endometriosis, other than scarring from having the ablation done, you may also have what's called adenomyosis. Has anyone heard of adenomyosis before? Okay. So basically with adenomyosis, what you have is an overgrowth of the muscle of the uterus. And if you have an overgrowth of the muscle of the uterus, the only treatment is hysterectomy. So keep that in mind. And the only way we'll know if you had adenomyosis is for us to biopsy your lining. Now, before you have hysterectomy, period, someone should be doing an endometrial biopsy and making sure that your tissue is normal. I would assume they did that prior to you having your embolization. So that's just something to keep in mind. Hello, Armenia. Thanks for joining. Thanks for joining. And you're saying yes to which part, Armenia? Oh, no. Okay. All right. So any questions about painful periods? Does anyone have any questions in reference to painful periods? Are we good on that? Okay. All right, so let's go to our next question. I will not share your name when you send an email unless you tell me to, but otherwise I will not share your name. This listener said, hello, Dr. Cyn. I'm loving your Facebook Live segments on teaching women about women's health. I just started taking Divigel hormone replacement. How long does the side effects normally last? What is the best hormone replacement and the most effective ones to use? Very good question. So you guys okay? Oh, hold on one second. Armenia says, I know what endometriosis is. Okay, great. Thanks, Armenia. All right, hormone replacement therapy. This is a good topic, and really I plan to do an entire night just talking about hormone replacement. But I'll give you guys the quick and easy, and hopefully I am answering your questions. If I have not answered your question, please put your question in the chat, and I'll try my best to answer whatever additional questions you may have. All right, so basically, as we get older, as we mature, we lose a lot of our hormones. And women develop hot flashes, they can develop mood changes, they can see changes in their skin and their hair, vaginal dryness, things of that nature. All right, one second. Yes, Armenia, what is your question? Go ahead and put your question in the chat. All right, I'll keep rolling until I see your question, Armenia. Okay. So when women have this situation, we can replace your hormones. And hopefully that will relieve your symptoms. So you don't have to worry so much about being miserable as we go through what a lot of people like to call the change. Now, I know a lot of you guys have heard about the Women's Health Initiative, a lot of the studies being stopped, and that hormones aren't safe. Well, they can be safe. We just need to use them in the right way. Many years ago, we thought that every woman who went through menopause, that we are supposed to immediately put them on hormones because it's going to protect their hearts. Well, the study was stopped because there was a higher rate of strokes and heart disease, things of that nature. And what we've come to realize is that hormones kind of have a bimodal effect. That if you give it to someone right when they're going through the change, as long as they don't have contraindications to it, and we'll talk about those, then it can protect the heart. But if you wait and they've already stopped having periods 5, 6 years ago, then you're putting them at increased risk for heart disease if you started at that time. Okay, does everyone understand that? So right now, the only FDA approved reasons for taking hormone replacement therapy is if you're symptomatic with hot flashes, if you're having issues with bone weakness, things of that nature, then you can go on hormone replacement therapy. All right, 1 second here. Yeah, I know the chat is lagging. What do we have? Melissa Tate, thanks for joining. As you join, please like and share. She says, I definitely want to hear more about hormone replacement. All right. So, technically, we can give hormones before you go through complete menopause. All right. So, menopause is when you've gone one whole year without having a period. Now you're in menopause. Now that time frame when your hormones are just all over the place and you having hot flashes, but you still having some periods here and there, that's called the perimenopausal phase. And we don't know how long that's going to be for you. Some women it's just a couple years. Other women it could be 5 or 6 years. We just don't know. Okay. Now in that perimenopausal phase, you're still having periods. It's okay for your doctor to put you on birth control pills. It is perfectly safe. Even if you're 40, 42, 43, it's okay to be on birth control pills at that time. Or if you want to get like a Mirena IUD or something like that, that just gives you a steady state on a daily basis, that's okay. So we'll consider that part a little bit when we're talking about hormones. All right. Now, if you're postmenopausal, you've gone a year without having a period and you're having hot flashes, you got the vaginal dryness going on, things of that nature. And so your doctor starts to talk to you about hormone replacement therapy. There are some people who shouldn't have it. All right. If you have risk factors, if you're smoking, you don't need to go on hormones. If you have a history of breast cancer, if you have a history of any type of cancer that has positive hormone receptors to it, you should not go on hormone replacement therapy. If you have a history of heart disease, a history of stroke, if you have a history of high blood pressure that is uncontrolled, then hormone replacement therapy is not for you. We can talk about some other things that you can do, okay? Let me go to the chat here. Melissa Tate, what is your opinion of natural supplements like maca and feminescence? Okay, and then Tanya, I'll get to your question and then we'll go back to my talk. So when it comes to natural products, it's okay to take natural products for your hormones. But anything that has even phytoestrogens in it, if you have risk factors, then you need to be careful. Okay, I have many women who come and say, oh no, I'm not taking Prempro. I don't even want that because, it comes from the urine of this horse and things of that nature. But they're willing to do bioidentical hormones. And they feel that that's more natural, therefore it's safer. If you have risk factors, you don't even need to do the bioidentical hormones, okay? If you have risk factors, there's other medications we can use outside of hormones to help with hot flashes and things of that nature. Okay, for example, there is a pill called Brisdale. It is the only FDA approved medication for the treatment of hot flashes and it's non-hormonal. Okay, I should say FDA approved non-hormonal treatment for hot flashes. So you could do Brisdale. Some women we put on clonidine patches. Clonidine in higher doses can be used for blood pressure. And basically when you're having these hot flashes, what has happened is that your little vessels, those tiny blood vessels are having little spasms. And that's why the clonidine helps. When it comes to vaginal dryness, we can give you estrogen creams in the vagina without giving you oral medication. All right, it's okay for you to take the estrogen creams in the vagina, even if you have heart disease, because you really don't get that systemic absorption when we're only putting it locally in the vagina. So that's something else to think about. Yes, that's correct, Melissa. And Tony says, since minorities are more prone to double negative reproductive cancer, so shouldn't minority women with family history should be tested prior to hormonal replacement? So Tony, I'm not really sure what you mean when you say be tested. Now, what I recommend is when you go in for your annual exam, and we talked about this at our when we did our whole talk on ovarian cancer, that family history is important. And if you do have a family history of breast cancer, ovarian cancer, colon cancer, anything of that nature, then your provider should be talking to you about genetic testing, where we can check to see if you're at increased risk, if you carry the genes for like BRCA1, BRCA2, if you're at increased risk for Lynch syndrome, things of that nature. Now, if all those things are negative, then it's okay. Tony, does that answer your question? I hope I'm able to answer your question there. Okay. Any other questions before I go on? All right, so we talked about the risk factors. Now, the next thing that we need to talk about is what type of hormone replacement therapy is correct for you. So our listener said that she's taken Divigel. Divigel is a estrogen-only hormone that you can actually put directly on the skin. So you don't have to take a pill. It goes directly on the skin. If you still have your uterus, you cannot do estrogen-only hormone replacement therapy, okay? You need to also have progesterone if you still have your uterus. You guys get that? If you still have your uterus, you cannot do estrogen alone. You must have the progesterone along with the estrogen. And the reason being is that it can increase your risk for endometrial cancer if we're given a whole bunch of unopposed estrogen feeding that lining and there's no progesterone to protect it. So just keep that in mind. So for my reader, I'm assuming that she doesn't have a uterus anymore, and because they put her on Divigel. And it says, how long does the side effects normally last? So some of the side effects that you can have with estrogens, period, is sometimes people can have a little bit of a run of the symptoms that they normally had. Sometimes you can notice some irritation in the skin area where you're rubbing the creams on. I'm not sure if she means how long will the hot flashes last. Is the Divigel getting rid of your hot flashes? I'm not sure if you're here tonight or if you want to answer. Did the Divigel get rid of your hot flashes? Now, what we normally like to do when we start women on hormone replacement therapy is that we will put them on the lowest dose possible. If their symptoms are really, really bad, we'll start them out at a mid-level and see how they do. And then we can adjust the medication. Sometimes we have to go up, sometimes we can go down. And our goal is to put you on the lowest dose possible that will keep your symptoms away. Okay, that is our goal, having you on the lowest dose possible that will keep your symptoms away. All right, now, if I'm not sure what your side effects are, but if in any reason you start developing any chest pain, shortness of breath, any pain in your calves, any tenderness or redness in your extremities, I would recommend that you stop the medication immediately and go see your provider. So the next part of this question is, what is the best hormone replacement and the most effective ones to use? They're all good, and every person is different as far as what works for them. Okay? Do I feel bioidentical hormones are better than, your basic Prempro or your Divigel, if you don't have a uterus, things of that nature? No, I don't. They're all the same. When you do bioidentical hormones, you really need to know about the lab that your provider is using, so you really understand and know what you're getting. So that's important as far as that's concerned. Okay. So Tammy asks, what is the best thing to use for hot flashes? All right. So hormone replacement therapy is fine. You could definitely use hormone replacement therapy. Okay. There are all kind of different types. If you do not have a uterus, you got the gel that you can put on the skin. You got a spray that you kind of spray like perfume. Of course, you could take a pill. If you have your uterus, then you have to make sure that the product has both progesterone and estrogen in it. Other than hormones, what do you think about Premarin? So Premarin is estrogen, and that's fine if you do not have a uterus. If you had a uterus, then you need to use Prem Pro. But I don't have a problem with Premarin at all, as long as you don't have any contraindications to it. I think it works great. If you don't want to use hormones, once again, you could try the Brisdale. You can try the clonidine patch. That's something else the provider can prescribe for you. You can try soy supplementation, SOY, soy supplementation. There's soy milk out there. Soy has a lot of phytoestrogens in it, okay? So anything with a lot of soy in it, you can try that and see if that works for you. Now, some of the other natural products that are out there, it's okay to try and see if St. John's worts, things of that nature, as long as you don't have any contraindications. So before you take a St. John's wort, look at if you're on any type of daily medications, look at those meds and make sure that there are no contraindications, because sometimes there are, even for some natural products. And if you're not sure, just ask your provider. A lot of times you can ask the pharmacist when you go to pick your prescription up. Say, hey, I'm also taking X, Y, and Z. Is there a problem with that? And they'll let you know. You definitely want to be proactive. What about DHEA supplements? They're okay. Once again, it's whatever works for you. As long as there are no contraindications for you, then I'm okay with that. The Premarin hasn't been working. Well, Tammy, the first thing you want to do is make sure that they are titrating your dose to a dose that works for you, okay? Because there's multiple doses of Premarin, so you may just need a higher dose. Or maybe they want to add the Brisdale to the Premarin. Many women love the Brisdale. So even if you're on Premarin, they can add that to your formula and see if that helps you. So Armenia says, my doctor put me on Camilla and I hate it. I don't know. She says it has estrogen, but what do you think about it? It's fine. So tell me, what is it that you don't like about Camilla? Tammy says, I've used the patch and it helped, but it doesn't stop. I would add an additional agent for you, Tammy. I would really talk to my doctor about Brisdale and see if that's something that they're willing to give you. They shouldn't have a problem with that. Continue to take the estrogen, just add the Brisdale on top of it. And there's no problems with adding Brisdale. So Armenia, can you tell me what it is that you don't like about the Camilla? And if anyone else has questions, please put your questions in the chat. Please put your questions in the chat. So for my listener who wrote this great question in, I hope I have answered your question. If I have not, you can put it in the chat. If I haven't answered, if you have more questions, or if you want to email me, that's okay. Just email me at info@drcyn, OBGYN. All right. Armenia, I'm always hungry and thirsty. All right. Armenia, I would have them to try a different pill on you. All right. I would have them just to try a different pill and see if that works for you. Tammy, Premarin makes my blood pressure keep going, so they decrease my dosage. Yeah, I would keep, if Premarin is raising your blood pressure, you might need to come off of it, period, altogether. I would try the Brisdale and see how that works. I think that might be a good choice for you. And then try a little soy supplementation. Try some soy milk. Add that to your diet. You guys know Silk, the milk called Silk, S-I-L-K, that has soy in it. So just add some soy supplementation to your diet. See if your doctor would start you on Brisdale, and you might want to consider just getting off the Premarin, period. Now, if your pressures are good on a lower dose, then you should be fine. All right. Any other questions about hormone replacement therapy before I go to our next topic? Any other questions? All right. So, this is a good question. It says, thanks for giving us an opportunity to ask our questions. I was at my gynecologist appointment and I brought up WAP to my doctor. My gynecologist says that WAP is bad and no woman should be that wet. Is that real, or is my gynecologist wrong? Does everyone know what WAP is? Is anyone in the dark about WAP, what that is, or anyone have not heard the song or anything of that nature? So I guess everyone knows what WAP is. So basically, for those who don't know and just don't want to put it in the chat, i.e., I think my mom is listening tonight. I know she don't know what WAP is, and that's okay, Mom. That's Miss Mary. It's a song by Cardi B, and what she's talking about is a woman's vaginal wetness. And to me, it is okay for a woman to be wet. All right, that's how we're made. And long as you are aware of what is too much, WAP really in general is all about empowerment. It's all about the power of the vagina at the end of the day. Now, if you are having abnormal discharge where it has an odor, it's yellow, it's green, it's gray, or it's real clotty, anything of that nature, then that WAP is wrong. All right, you need to go see somebody because you likely have an infection. But if, when stimulated, you become very wet, there is absolutely nothing wrong with that. All right, that's something you should be proud of. There are no problems there. All right, any questions? Anyone have any questions in reference to that? Or are we all good? Now, if any of you other guys hear of any other providers telling you guys that the WAP is wrong, y'all need to let me know, because that is misinformation. That is definitely misinformation. All right, so I have one last question, and then I'll give a little bit of time for questions directly from our portal. Is that okay? All right, so my last question says, I keep having abnormal pap smears, and now they're telling me I need to wait a year, even though my last pap smear was abnormal. Okay, not really sure what you mean when you say abnormal as far as your pap smear is concerned, but let me just give you some basics when it comes to pap smears, because there's so much that has changed over the past, even in the past year. There's been a lot that has changed with the recommendations when it comes to pap smears. So it used to be many years ago that you got your first pap smear when you were 18 or when you became sexually active. All right. And a pap smear, for those of you who don't know, is a screening test for cervical cancer. It allows us to catch cells in a precancerous state before it even has the ability to turn into a cancer down the road. That precancerous state, we call that cervical dysplasia. All right, so it used to be as soon as you become sexually active or 18, whichever one came first. Then we transitioned to age of 21, that you didn't get a pap smear until the age of 21, because what we realized is that there were a lot of women who were, or young girls who were having a lot of procedures done on their cervix when the likelihood of them progressing to cervical cancer was low. Okay, now they're saying 25. So I don't want people to be confused and think you don't have to go see the gynecologist until you're 25. You still need to be seen, especially if you're sexually active. Okay, let's see. Armenia says, my doctor says come back in 3 years as opposed to every year. I don't believe that. Well, the reason why your doctor likely said to come back in 3 years is because when they did your pap smear, which likely was normal, they also tested you for high-risk HPV, and that was negative. And we know that if your pap smear is normal and your high-risk HPV is negative, then we can wait 3 years before we repeat your pap, because the likelihood of you developing severe dysplasia or even definitely cervical cancer is extremely low in that period of time. High-risk HPV, or human papillomavirus, we know that's the culprit that causes cervical dysplasia or even cervical cancer. Now, that doesn't mean that everyone out there with high-risk HPV will get cervical cancer. It's just you got to have it in order to develop it. Most people who have HPV in their system will never have cancer. All right. But if you do not have HPV in your system at that time and your pap smear is normal, then they're comfortable waiting 3 years. And that's one of the other things that is changing. They are now, just this year, coming out and talking about waiting 5 years, or only doing HPV testing and not the pap smear at all. I'm not very comfortable with that right now, especially in women of color. We do know in women of color that the aggressiveness in cervical cancer is a lot higher, and there needs to be a lot more research done. So I myself am not comfortable waiting 5 years, but I am comfortable with the 3 years. Hello, Martha. Thanks for joining. It said, should you have a PAP if you've had a hysterectomy? So hysterectomy is removal of the uterus. And most of the time with hysterectomy, it's a total hysterectomy, and they remove the uterus and the cervix. Every now and then, women have what's called supracervical hysterectomies, and they leave the bottom part, which is the cervix. If you have a cervix, then you need to continue to get pap smears done. If you've had a hysterectomy and you do not have any history of moderate to severe dysplasia, then you don't need to get a pap smear anymore. If you still have your ovaries, they still need to be filling your ovaries and making sure that your ovaries feel normal. I still recommend for someone to put a speculum in there periodically to look and make sure there are no lesions in the vagina. Make sure that vaginal cuff from where they removed the uterus, that everything looks good. So you still need to be seen once a year. Any other questions right now? All right, so that is it as far as our questions for tonight. I didn't want to overwhelm you guys with too much information. I do have something to share. You guys can go ahead and mark your calendars on November 7th. That's a Saturday. November 7th, I will be doing a free webinar on uterine fibroids, okay? So look out for the advertisement for that. But November 7th, I'll be doing a free webinar, free. You guys hear that? Free, on uterine fibroids. So once again, let's see. Hold on, Armenia. If my insurance pay for it, is it still okay to do your yearly, or can I feel comfortable with the 3 years? It's whatever makes you comfortable. And if your insurance still pays for it, go ahead and get it. It's not going to hurt anything. Okay. But regardless, even if you wait 3 years to repeat your PAP, you still need to be seen every year. We still need to be putting our hands in there every year, making sure that those ovaries feel normal. We need to be looking at the vagina, making sure there's nothing going on inside the vaginal canal itself. Okay? So I hope I've answered your questions. Once again, I am Dr. Cyn, your board certified OBGYN, national speaker, and vulvar skin specialist. I help women to understand and optimize the skin care of the private face so they are able to realize that this area can be just as beautiful as their public face. And once again, November 7th, I will be having a free webinar on uterine fibroids. So please look out for that advertisement. And I hope you guys have an enjoyable evening. Good night.